Hello and welcome to this COVID-19 online educational program from Virology Education. It's a great pleasure to welcome you to this second in the edition. I'm Anton Posniak and I'm a physician in London. Now, I'd just like to go through some of the things that we're trying to do today in terms of our learning objectives for this program. We're going to understand the key factors that influence the need for social distancing. We're going to have updated knowledge of potential drugs for COVID-19 and gain a basic understanding of the key issues in the care of severe COVID-19, especially those patients that are admitted to ICUs. So you can see there's going to be fantastic topics today to cover in this program. Now I'd like to introduce the faculty to you. So it's a great pleasure to introduce Charles Boucher from the Netherlands and Jonathan Shapiro from Israel, who have been the real powerhouse in making this program available to you, together with the people from Virology Education. But also Dan Kuritzkes, who's going to be speaking tonight around the treatment of HIV, and myself, who's chairing this program tonight. So the first talk is from Yonathan Grad, who's from the Harvard Chan School of Public Health in the United States. And he's going to discuss today one of the big issues for us. It's about social distancing and COVID-19. Where do we go with this? So Yonathan, it's a great pleasure to introduce you to this program, and we're looking forward now to your discussion and talk.
Hello, I am Yonathan Grad. I'm an assistant professor of immunology and infectious diseases at the Harvard Chan School of Public Health and an associate physician in the Division of Infectious Diseases at Brigham and Women's Hospital, Harvard Medical School. Today, I will talk about some of our work using modeling and other approaches to understand social distancing and COVID-19 and give a sense of our projections as to where we are headed. To begin, I will refer to a piece that my colleague and friend Mark Lipsitch and I wrote about a month ago. At the time, when we were just starting with social distancing and just starting to flatten the curve, to use a phrase that I suspect many are now familiar with, we described how we were just really clambering into a life raft and that dry land is far away. And what we're referring to is the idea that even though we were responding in a robust fashion to the pandemic, there is quite a time, quite an amount of time between those responses and really how, or the timing of the ending of the pandemic, that we're just in the first phases of the response. So I want to provide a framework for thinking about how the pandemic ends. There are two possible ways. I'll start with the second one. We could eliminate the virus. This is what happened with the 2003 episode with SARS. There, an incredibly strong, robust public health response led to control of SARS and eventually its elimination. The other possibility is population immunity. Now, with the elimination of the virus, I think it's now with the virus spread all around the world, I think the second possibility is extremely unlikely. And instead, we're really looking at this first one of population immunity. By population immunity, I mean that enough of the population has to be immune such that we see the end of spread. When does that happen? Well, that has to do with how transmissible the virus is. This gets to another term that I think has been a fair bit in the news recently, and this is the R0, or the basic reproductive number. It's in essence the transmissibility of the virus. For SARS-CoV-2, we think that number is around 3. So what does that mean? Basically that we need to have 2 out of 3 people already immune in order to see that transmission chains will start to slow down. So the R0, this value of 3, means that on average, an infectious person will infect 3 other people. We need to get that, again, below 1 in order to see the end of the pandemic. And so that means more than 2/3 of the population needs to be immune. How can that happen? Well, if infection and recovery then confer protective immunity, one way is to have around 2/3 of the population infected. The other way is for people to get immunity from a vaccine. Right? So if we find an effective vaccine and give it to enough people to achieve over this 66, 67%, then we can see population immunity. So this is really kind of the mindset that we need to have to understand what our options are. This figure comes from Debbie Birx, and the White House Task Force. And it's, again, one very familiar with people, and it helps to shape, again, our understanding of the options that we're facing. So how can we get to this herd immunity? One option is to just let the epidemic go, and we see that this will cause a large number of deaths. That's both because of the unmitigated epidemic, but also because when we have this huge strain on the healthcare infrastructure, we expect that it will potentially lead to the collapse of that infrastructure, and that not only would people die from COVID-19, but also the inability to get care for heart attacks, strokes, and other medical conditions that they would normally be treated for. And then as well, there would be huge economic impact to the collapse of the healthcare system. So what we're trying to do is, as demonstrated by this lower curve, is to flatten the curve, right? And the idea here is that it will help maintain the healthcare infrastructure, that by slowing the rate with which people are getting infected, by engaging in social distancing and trying to slow the spread of the virus, we will not overwhelm the hospitals and other healthcare institutions. And that it will also give us time, we hope, for the development of other interventions, effective medications, vaccine, and so on, that together will help slow the impact and lessen the impact of the virus. So knowing that we're not going to be able to eliminate the virus, and that we're really looking at this an end game where we have population immunity, there are three possible paths we can take. The first is to stop the social distancing that we've started and just let the epidemic go. The second is to try social distancing to flatten the curve and kind of achieve this balance that I was talking about before, of not having so many cases that we overwhelm our healthcare infrastructure, but also we're not kind of towards the end of trying to reduce the spread entirely. That is the third option, that we combine social distancing with case identification, contact tracing, isolation, and quarantine, and try to not just flatten the curve, but crush it. And this basically means that we'll try to prevent all cases and maintain the population as susceptible, so that a large fraction of people will still be susceptible to infection. And then we wait for a vaccine, because again, we need to figure out some way to get up to this level of herd immunity. The first option is bad. In fact, all of them are bad, but some are clearly worse than others. So letting it go is a bad option. Here we have data from Wuhan. So Wuhan shut the city down when they had 500 confirmed cases in a population of around 10 million, which is about the size of New York City, a little bit larger. And they reached a per capita demand for ICU beds equal to fully occupying the ICUs available in the US just for COVID-19, so absent all other medical conditions. And it took about 4 weeks from this shutdown to peak ICU need. And so that gives you a sense of the delay between taking action and the amount of spread that has already happened and the time it takes for people to then present to hospitals and critical care units. So we know this is a bad option. We've seen it in Wuhan, we've seen it in northern Italy, we've seen it in New York, right? The amount of devastation that can happen in the absence of intervention, or even if interventions are delayed. So this leads to a question: if we are continuing on with social distancing, how long will it last? This is particularly operative now when we're seeing different states and different places around the world start to lift their social distancing interventions. So what what's going to be the impact of stopping social distancing at different time points. So this is something that we investigated in a paper that was published a few weeks ago in Science. And I'll take you through some of the results in this paper. So one of the first things we were interested in is whether there is seasonality. So this is a question that has arisen from the first observations of COVID-19. Do we expect that there is augmented spread in the winter and diminished spread in the summer, like we see with other respiratory viruses such as influenza? To ask this question, we thought we would look at other human coronaviruses, particularly the two beta coronaviruses that already circulate in human populations, HKU1 and OC43. And we used data from surveillance systems in the United States to get a sense of the extent of seasonality. And we can see that in these plots here. And sure enough, for these other beta coronaviruses, the ones that are, again, closest in circulation to SARS-CoV-2, we can see that there is seasonality. So this then became the model for which we could ask about SARS-CoV-2 seasonality. Again, we don't know for sure whether there is seasonality, but this at least gives us a benchmark that we can use when exploring what might happen and starting to make projections about possibilities going forward. So here we look using a standard epidemiological model that models infectious disease dynamics, what might happen under various scenarios. So in the black line, we have no intervention. In the red line, we have modestly successful social distancing. In blue, more successful social distancing. And in green, social distancing that was as successful as what was seen in Wuhan. So very aggressive lockdown. And the dotted lines reflect the critical case, the critical cases, the incidence of critical cases in, and again, you'll see them delayed by a little bit. This goes back to the observation from Wuhan that it takes a few weeks from your peak of cases to then see the peak demand in the critical care units. Here, the purple boxes reflect the duration of social distancing interventions. So we have social distancing of 4 weeks, 8 weeks, 12 weeks, 20 weeks, and indefinite. The main point to make here is that as we have social distancing that is varyingly successful, the extent to which it is successful helps determine what will happen afterwards. So if it is very successful, as in the green lines, what we'll see is very few people infected during the social distancing effort, but those people remain, the rest of the population remains susceptible. And so we will see, once we stop social distancing, again, the rise of a resurgence in infections. So to the extent that we're successful in maintaining a susceptible population by diminishing spread, once we stop our social distancing efforts, we'll see peaks arise again. Now they're smaller than the original peaks, but nonetheless, we will see a resurgence once we stop. That was in the absence of seasonality. Now, what if there is seasonality? Again, diminished spread in the summer and increased spread or augmented spread in the fall and winter. But here, our social distancing efforts at this time of year, at least in the Northern Hemisphere, are augmented themselves by the diminished spread, meaning we are more successful in our social distancing efforts over the summer. But once we get to the fall and winter, the increased spread associated with seasonality, the increased transmissibility of the virus associated with seasonality will lead to even bigger peaks in the fall and winter. So in the absence of seasonality, we'll still see, we'll see a resurgence. And in the presence of seasonality, we'll see even bigger resurgence in the fall and winter. So to summarize, for one-time social distancing interventions, if seasonality is negligible, then all social distancing helps, and long, moderate social distancing is best. If seasonality is present, then long, weakly effective social distancing is best, but strongly effective social distancing can actually make things worse by delaying the peak into the winter. And again, we'll see both increased transmission, But also, at that point, it will coincide with the influenza season, which already stresses the healthcare infrastructure, and I think will lead to even greater problems. So we suspect that there will be some seasonality, so our one-time interventions could actually make things worse in the absence of other interventions. Now, since we responded to starting to see the first peak with social distancing, we wondered, well, if we're going to stop social distancing and then start to see another peak, maybe we'll start social distancing again. And this leads to a notion of cycled or intermittent social distancing. There are many different ways to envision how this might take place. Here we just present one of them, which is perhaps the simplest and most optimistic of a very aggressive social distancing. And this is in the absence of other types of interventions. So this is not including contact tracing, not including new medications, or other types of interventions that themselves might have an impact. This is really just thinking about cycled social distancing alone. And so when would we start social distancing? Well, we'd start it when we set some kind of thresholds that we would predict would threaten the healthcare infrastructure, right? Again, that is the balance that we're trying to strike here. And we would need to keep on doing this with on when we know we're heading towards this threshold for critical care cases, and turn it off as we're coming down, and then on again and off, a kind of thermostat model. And doing this repeatedly until we start to approach herd immunity. But this kind of approach without seasonality is, and given our current ICU capacity, would take quite a long time into 2022. Seasonality helps us a little bit because we'd have longer periods in the summer because there'd be decreased transmission, but it would still take quite a long time. Now, if we were to double our ICU capacity, it gives a little bit more breathing room, so to speak. And having new medications mathematically basically is the same thing as increasing capacity, because it slows or it reduces the number of people who enter into the hospital and from the hospital into critical care beds. So it can function basically similarly. And having increased ICU capacity basically allows us to spend more time and that will get us to herd immunity faster. And then again, with seasonality, that can help accelerate this as well, so that we could have fewer rounds of this type of distancing. So if there's no seasonality, then we would have, with intermittent distancing, a slow accumulation of herd immunity. Seasonality is helpful in this scenario, and that longer time off due to summer slowdown will be helpful. And then increasing our ICU capacity or other types of interventions could allow for longer breaks and faster accumulation of herd immunity. This, however, really requires having good surveillance. Again, it was the decisions to turn on and off social distancing are in this case really tied to being able to carefully track the number of cases and hospital capacity. And of course, this is something that requires intense political and social will. And there are, as with all interactions with diminishing interactions, all lockdowns, it has big economic consequences. And so it will really require some careful thought and strategizing. Now, the third option that I mentioned is to combine that social distancing with contact tracing and quarantine to try to crush the curve and prevent all transmission. And in this paper, which is now in press in Lancet Infectious Diseases, we looked at the type of interaction, or what happens when you combine social distancing and contact tracing, quarantine and isolation, and we're able to show that they synergize. But what I really want to underscore is that contact tracing is not itself the intervention. The intervention is then quarantine or isolation. Quarantine for people with their contacts and isolation for those who are known to be infected. And that also requires intense support of the population in order to try to make that intervention actually happen. So in this third option, let's say we're actually successful. We flatten the curve or crush the curve with aggressive case finding, contact tracing, isolation, and quarantine, and really try to prevent all ongoing transmission. So the problem here is that the extent to which we're successful, unless there's a lot more spread than we're aware of, and many, many asymptomatic individuals who have been infected and recovered without our knowing about it, if there's a substantial fraction of the population that remains susceptible, we will need to continue to have these interventions in place until we get a vaccine. And those interventions are going to be remarkably restrictive and could include monitoring all travelers or even restricting domestic and international travel. Because again, there will be some places in the world that choose option one, other places that choose option two, where we'll see the virus continuing to transmit. And we'd have to prevent those individuals who are carrying the virus, even carrying it asymptomatically, from getting in and starting epidemics again. Singapore, with arguably the world's best public health system already trained by the first round of SARS and worried about a variety of other types of respiratory outbreaks, has tried this approach. So they have very aggressive contact tracing, isolation and quarantine. And even Singapore has had resurgence, has had little flare-ups that led to a 4-week lockdown. So this kind of approach will require remarkable vigilance. And then even in this approach, we should expect to see at least in some cases flare up, and the possibility of having to institute additional social distancing measures on top of these. So what do we do now? This slide I originally wrote around 1 month ago at the beginning of April, and here we are at the beginning of May, and I think many of these principles and needs still apply. We need to build capacity to control transmission by continued social distancing. We still have a massive deficit in testing. We need to get that ramped up. And we need to meet the needs of healthcare workers for personal protective equipment. We still don't have enough PPE. We need to invest in efforts to mitigate the impact of COVID-19 by rapidly finding treatments. There's been some advance with remdesivir, but we need more. We need treatments that are oral, that can be given out outside of the hospital, and that are effective and potentially even are prophylactic. We need to increase our healthcare capacity. We've seen many hospitals convert even operating room ventilators into ones that they can use in intensive care units. And we may need to really bolster that capacity as we anticipate future resurgence. And we need to really accelerate the work on a vaccine, because again, it's only that combination of either immunity from infection or immunity from a vaccine that will bring us to the end of the pandemic. One of the types of testing that we'll need is serological testing. Because we didn't have the diagnostic testing that would really allow us to track the epidemic from the beginning and get a sense of how many people are infected and where and how it's spreading, we now need to use serologic diagnostics that tell us about people who have had past infections to understand where the disease has been and how it has spread. And there are multiple challenges to designing and interpreting both prevalence and seroprevalence surveys, but we and many others are trying to develop these types of surveillance studies. Having thought hard about what these studies should entail, we and the challenges involved in developing them, we developed a statistical framework to help with seroprevalence analysis, forecasting, and study design. This is available on medRxiv, so you can find it online. And it helps with both convenience and formal sample schemes. So you can go from newborn blood spots or US blood donors or other types of survey designs to inferences about seroprevalence in populations, and then to develop the epidemiological parameters that can inform modeling and policy decisions. And we have a website where we have calculators that can help with this as well. So with that, I'd like to acknowledge all of my collaborators and the citations of the papers that I've mentioned over the course of this talk. You can find more information in each of these papers. Thank you so much for your attention, and have a good evening.
Yonathan, thank you very much. That was very interesting, especially the the predictions at how long it would take us to get herd immunity without other major interventions. There are quite a lot of people asking about the effect of climate on transmission. And obviously, you know, in the north and in the south, we have a lot of seasons, whereas along the center, their seasons are rather different. Their temperatures are more constant. Are there any data on transmission and temperature variability or climate variability?
Not as yet. It's a question, of course, that many people are interested in. There was hope initially that as we enter into warmer weather, we'll see a decline in transmissibility. But we know as well that there's been transmission in very warm places, for example, in Singapore. Whether there's a relative decline that is attributable either to temperature or to humidity. As we know with flu, for example, absolute humidity influences transmissibility. We still don't know yet for SARS-CoV-2. So that the jury's still out on that one.
Okay, and we have to wait to see if we have seasonality here yet. So it's
exactly
it's
right.
a really interesting question. All right, so we're going to have quite a lot of questions in the round table. Thank you for everybody who's sending their questions in, and we're going to try and answer as many as possible. Obviously, there are many of you online, so that may not be. So please don't get too anxious if we don't get to your question, but we will try in the round table to cover a lot of ground. So thank you, Yonathan. I'm looking forward to discussing a lot more about what you've said when we get to the round table.
Great, thank you.
So our next presenter is Professor Daniel Kuritzkes, who's he's a professor of medicine at Harvard Medical School. Dan gave us an update on therapeutics for COVID-19 at the last edition, and things are changing so fast. I think we need this as a permanent thing to keep going on, to look at what is happening in treatment for COVID-19. Dan, I'm looking forward to this very much indeed. Thank you.
Welcome to this update on therapeutics for COVID-19. I'm Dr. Daniel Kuritzkes, Chief of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School here in Boston. This slide shows my disclosures. Today I'm going to be discussing several different approaches as treatment options for COVID-19. None of these has yet been proven to be effective therapy for this infectious disease, but there are numerous studies ongoing around the world, and I'll try to provide an update on as many of them as we can cover. This list is certainly not exhaustive, and in future updates we'll try to cover additional topics. Let's start with antiviral therapeutics. This slide shows a schematic of the life cycle of SARS-CoV-2, the virus that causes COVID-19. SARS-CoV-2 is a single-stranded RNA virus that is enveloped, and the S or spike protein of the envelope engages the angiotensin-converting enzyme 2 as its primary receptor. This results in entry of the virus particle through endocytosis into the cell, where it undergoes uncoating. And the process of exiting the vesicle may be inhibited by agents that prevent acidification of the vesicle, such as hydroxychloroquine. The RNA is then reproduced by an RNA-dependent RNA polymerase, and several of the drugs that are being studied as potential therapeutics are RNA polymerase inhibitors. Following RNA transcription and reproduction, there is a translation of RNA into proteins, which need to be processed, as is the case for many viruses. Then the virus buds out and can go on to infect other cells. One of the first antiviral drugs to be studied was lopinavir in combination with ritonavir, the HIV protease. There's a question about why lopinavir might have any activity against SARS-CoV-2, since the HIV protease is an aspartyl acid protease, whereas the SARS-CoV-2 enzymes are serine proteases. However, there was some in vitro evidence, as shown in the upper right panel here, that lopinavir has antiviral activity against SARS-CoV-2 with an EC50 of just under 12 micromolar. There have also been retrospective case control series suggesting a benefit of lopinavir in the original SARS outbreak of nearly a decade ago. This led to a randomized clinical trial that was conducted in China, comparing lopinavir-ritonavir to a placebo, which was published in the New England Journal of Medicine several weeks ago, and showed no benefit overall in terms of survival. Interestingly, though, there did seem to be a potential benefit in patients who received treatment after fewer than 12 days of illness, so those who were treated earlier. And so there may still be some room to explore use of lopinavir in earlier stage patients. The drug that's perhaps received some of the most attention is hydroxychloroquine. This, of course, is a drug that serves as both an antimalarial, it's a derivative of chloroquine, as well as an anti-inflammatory drug that's widely used for the treatment of lupus and rheumatoid arthritis. There are two potential modes of action for hydroxychloroquine. One is as an antiviral drug through its inhibition of acidification of endosomal vesicles, and the other as an anti-inflammatory, perhaps moderating some of the inflammatory consequences of SARS-CoV-2 infection. Shown in the upper right panel here are data inhibition curves for hydroxychloroquine and chloroquine in vitro inhibition assays, and you can see that the EC50 is at around 4 micromolar. There have been mixed results from clinical trials reported to date. A report out of France suggested that there was more rapid shedding, more rapid loss of shedding of SARS-CoV-2 in patients treated either with hydroxychloroquine alone, shown in this blue line, or hydroxychloroquine plus azithromycin, shown in the green line, compared to patients who received no treatment, shown in the black line. However, there were some concerns around potential bias in the way that these studies were conducted, because some patients had progression and ended up in the intensive care unit and were no longer sampled and therefore removed from the analysis. And subsequently, these data have actually been retracted, and other data presented that show no effect of hydroxychloroquine on viral shedding. Nevertheless, there are several large clinical trials that are underway with appropriate controls, the results of which will provide a definitive answer about whether or not hydroxychloroquine is effective. There are concerns, however, about the use of hydroxychloroquine, either alone or in combination with azithromycin, in terms of the effect of these drugs on cardiac conduction, specifically prolongation of the QT interval. You can see here in this very recently published paper from JAMA Cardiology that nearly everybody who received hydroxychloroquine had an increase in the QTc, with some patients having intervals that increased above 500 milliseconds, those shown in orange. If they received hydroxychloroquine with azithromycin, you also see a substantial increase in a subgroup of patients reaching more than 500 milliseconds. In this study, one person in the trial did develop torsade de pointe, which of course is the ventricular arrhythmia of greatest concern in patients with QTc prolongation. There have also been preliminary data, still unpublished but posted online, showing that at least with hydroxychloroquine alone, there was actually an increased mortality compared to those who received neither hydroxychloroquine nor hydroxychloroquine with azithromycin, and this was statistically significant. However, this study was not a randomized trial, and there could very clearly have been allocation bias where the sickest patients received drug. So we really won't know whether hydroxychloroquine has a benefit or it has more harm than benefit until we see properly conducted randomized placebo-controlled trials. Let's turn briefly now to talk about favipiravir. This is a broad-spectrum viral RNA polymerase inhibitor. It's been approved for use against influenza in Japan, but not yet in the United States. this drug has activity against SARS-CoV-2 in the laboratory, shown again in the upper right panel of the slide, but with an EC50 of about 62 micromolar, substantially greater than what was seen for hydroxychloroquine or even for lopinavir. This is a concentration, however, that is achievable with dosing in humans using the dose approved for influenza. And a non-randomized pilot study showed more rapid clearance of SARS-CoV-2 from pharyngeal secretions of patients compared to those who received lopinavir, and there are now several trials underway. The drug that has shown the greatest promise to date is remdesivir. Like favipiravir, remdesivir is an RNA polymerase inhibitor with in vitro activity against a range of RNA viruses, including Ebola, SARS, MERS, and SARS-CoV-2. Remdesivir was actually studied in a phase 3 trial against Ebola, where it proved to be inferior to broadly neutralizing antibodies. However, as shown in the upper right-hand panel, remdesivir is really quite potent against SARS-CoV-2 with an EC50 just below 1 micromolar. And in studies done in murine models and in non-human primates, the drug has been shown to protect against lung injury. These photomicrographs here show what the lung looks like in animals that just received the control, where you see lots of inflammation and accumulation of fluid compared to the remdesivir-treated animals that had some inflammatory cells, but the alveoli remain relatively clear, and then in the left panel, mock-infected animals. In addition, in the non-human primate studies, compared to the control, infected monkeys who received remdesivir for treatment had significantly lower virus loads in their secretions, and when given as prophylaxis, it was highly protective against acquisition of SARS-CoV-2 infection. Preliminary data from a compassionate use study of remdesivir were published a couple of weeks ago in the New England Journal of Medicine. This study didn't have a control arm, so we're really just looking at overall survival and improvement and discharge, and approximately 68% or so of participants showed improvement and were discharged home if they received remdesivir, and that's compared to about 30% of similar patients from the experience in Wuhan. Obviously, that's a very difficult comparison to make because this was a US-based study done several months after the data had been collected in Wuhan. But even if you looked here in the middle panel at those who required invasive ventilatory support, the survival rates for those who received remdesivir were substantially greater than those that had been reported previously. There are now quite a few different remdesivir trials that are ongoing or have been reported either completely or in various stages. Those include the compassionate use protocol, whose data I just showed you, data from the ACT-1 study, which was a randomized clinical trial of remdesivir versus placebo for patients who had significant hypoxia or requiring supplemental oxygen or mechanical ventilation along with pulmonary infiltrates. And there were, the total sample size is close to 1,000 participants, but data are now available on a subset of those. Severe disease study in China that has been reported of remdesivir versus placebo in only 237 participants. And then 2 studies being done by Gilead, one in severe disease and one in moderate disease. The study that has received a great deal of attention since it was first preliminary data were released last week is the ACT-1 study. This is a study sponsored by the US National Institutes of Health. And it is a randomized, double-blind, placebo-controlled, multi-center study in hospitalized patients with COVID-19. Patients were randomized to receive either a loading dose followed by daily intravenous remdesivir for up to 10 days or placebo, the primary outcome being time to recovery over the first 28 days. The data that have been released thus far show that looking at time to recovery, there was a 31% reduction in time to recovery, which was highly statistically significant, 11 days versus 15 days for placebo. This led the DSMB to halt the randomized part of the study because a significant advantage was demonstrated for intervention. However, there has not yet been demonstration of a survival advantage. There was a numerical advantage with only 8% of remdesivir treated versus just under 12% of placebo recipients dying. And that just missed being statistically significant. But we'll really need to see the outcome from the entire data set to know whether there is, in fact, a survival advantage or not. In addition, Gilead released data from its SEVERE trial. Remember, this was a study done in people who had O2 saturations of less than 94% on room air, or who required supplemental oxygen to maintain an SaO2 of 94% or greater, or were receiving mechanical ventilation. This study compared two different durations of therapy of the same dosage of remdesivir, either 5 days or 10 days, but there was no placebo group. What the study found was that overall, there really was no statistically significant difference between the shorter and longer course of therapy, and therefore that study has been completed, but continues now in a open label format where participants continue to be accrued, and if they are on a ventilatory support, receive up to 10 days of intravenous remdesivir. A study in China has been done that is a randomized clinical trial of remdesivir versus placebo in severe disease. That one, like the Gilead study, required, and like the ACT study, required an SaO2 of 94% or less and the presence of pulmonary infiltrates. However, the study was terminated for futility due to under-enrollment because the epidemic in Wuhan came to an end prior to the time that the study could be fully enrolled. So what we really have are top-line results that were unintentionally released by the WHO and then removed from their website. But what we can glean from that transient posting is that the hazard ratio for time to clinical improvement really did not achieve clinical significance. You can see the confidence bounds cross 1. And there was also no advantage in terms of 28-day mortality. And remdesivir was stopped early for adverse events in just under 12% of participants compared to 5% who had to stop a study drug in the placebo arm. Now, in placing these results in context with the ACT-1 study and the Gilead uncontrolled study in severe disease, it's important to note that this study was terminated before reaching full accrual. So it's really an underpowered study and doesn't really contradict the results of the ACT-1 study. As a consequence of all of these data, remdesivir is now released under an emergency use authorization in the United States for use in patients whose clinical characteristics match those of participants in the SEVERE trial. That is an O2 saturation of 94% or less on room air, or needing supplemental oxygen, or being on mechanical ventilation or extracorporeal membrane oxygenation. The distribution of this drug in the United States is still somewhat uncertain because it is being handled by the US government rather than by the manufacturer, and the mechanism for accessing drug remains controversial. The important points are that For patients who meet entry criteria, if they are mechanically ventilated, then 10 days of treatment are recommended, and if they are simply on supplemental oxygen, 5 days of treatment are being recommended. Also of note, the drug can be started even while awaiting results of SARS-CoV-2 testing in order to start drug as early as possible. This EUA is being administered not as a clinical trial, so participants or patients don't need to give consent, but they do need to be provided with a fact sheet about remdesivir. It's important to be monitoring renal function and liver function tests for patients who are receiving the drug, and the drug is not recommended for use in patients with advanced renal insufficiency with eGFRs of less than 30 mils per minute. And treating clinicians are obligated to collect and report serious adverse events in those receiving remdesivir, as well as to report any dosing errors. Well, let's turn to a discussion of anti-inflammatory drugs. We know that the illness caused by SARS-CoV-2 has several stages, where the initial stage is really dominated by viral infection and then transitions to a pulmonary phase, followed by a hyperinflammatory phase, which is really determined by an exuberant and inappropriate host inflammatory response that leads to and perpetuates lung injury, which requiring prolonged support with mechanical ventilation and often leading to death. So this second phase is characterized by a cytokine storm and very high levels of IL-6, which has led to a number of pilot studies looking at monoclonal antibodies that are able to either bind IL-6 or block the IL-6 receptor in order to interrupt this cascade. And you can see in the panels here on the upper right, data from a pilot study of tocilizumab, an IL-6 receptor antibody, showing decreases in C-reactive protein and decreases in fever among this group of participants in an open label pilot study. In addition, we've seen partial data from 2 studies of IL-6 receptor blockers. Sarilumab, which acts similarly to tocilizumab, is in a phase 2/3 study, where the phase 2 study suggested a potential benefit for people who were receiving the higher dose of sarilumab, 400 milligrams. You can see here that mortality was 23% compared to 36% in the high dose group. And those who died on a ventilator was 32% compared to 46% in the low dose group and 55% in the placebo group. This led the sponsor to modify the phase 3 component of the trial to eliminate the low dose and just proceed with a 2-arm study comparing the 400 milligram dose to placebo. Preliminary data were also released, perhaps unintentionally, from a tocilizumab pilot study in which nearly 130 patients were randomized to either standard of care with tocilizumab or to standard of care alone. This was an open label study. There was a significantly lower proportion of patients who reached the primary outcome in the tocilizumab arm. This release has generated some controversy because the results were really interim results. And now there is a larger, actually several larger tocilizumab studies being done by different groups around the world, and we await the results of those trials. With those preliminary data, there has been a literal flood of additional drugs targeting various aspects of the inflammatory cascade that have entered into clinical trials, including many different monoclonal antibodies, as shown in this column on the left, several of the JAK inhibitors or Bruton tyrosine kinase inhibitors, as shown in this middle column, and other agents such as abatacept, as shown in the right-hand column. And these are only the studies of which I am aware. There are undoubtedly many others that are ongoing. Well, what about the renin-angiotensin-aldosterone system and its role both in disease and potentially as a therapeutic target? As we discussed at the beginning of this talk, we know that the SARS-CoV-2 virion binds to angiotensin-converting enzyme 2, the primary receptor for the virus. When the virus binds to the receptor, this causes downregulation of receptor expression. The enzyme, however, is crucial for metabolism of angiotensin 2, which is part of the angiotensin cascade. When angiotensin 2 is not metabolized by ACE2 to angiotensin 1,7, the breakdown product, this leads to unopposed action of angiotensin 2, which can bind then to the angiotensin 2 type 1 receptor, and leading to acute lung injury, adverse myocardial remodeling, vasoconstriction, and increased vascular permeability. On the other hand, blocking the angiotensin 2 receptor leads to an increase in ACE2 expression, which might potentially facilitate virus entry and make infection worse. So there's been a big question about how the balance between expression of angiotensin 2 and blockade of angiotensin 2 receptor might play out in people with COVID-19. We have some preliminary data that are reassuring. These are data from China, roughly 1,100 or 1,200 patients who were followed, who continued receiving either an ACE inhibitor or an angiotensin receptor blocker because of hypertension during their hospitalization for COVID-19. And in this study, there was actually lower mortality among those who continued to receive these drugs compared to those who were not receiving these drugs after controlling for other covariates, including the presence of hypertension. In addition, a recently published paper in the New England Journal of Medicine looking at data from the United States and analyzing the independent predictors of in-hospital death in a multivariate logistic regression analysis examined the association of ACE inhibitor, angiotensin receptor blocker, or statin use at the time of hospital admission. Now, they didn't necessarily determine if people continue to receive these drugs, but people were getting these drugs at the time of admission. And you can see that there was significantly lower mortality for those receiving an ACE inhibitor or a statin, and no effect on mortality for those receiving angiotensin receptor blockers. So in aggregate, these data are quite encouraging that one can continue to use these drugs safely, whether they have a therapeutic role in people who don't require them for management of hypertension has not yet been answered. Let's talk briefly about convalescent serum. Convalescent serum from survivors of COVID-19 infection may contain high titers of neutralizing antibody, and this type of serum has been shown to have some benefit in the treatment of avian influenza, in epidemic H1N1, and in MERS. And an uncontrolled study published several weeks ago in JAMA showed that in 5 participants who received convalescent serum, 4 of these 5 were successfully weaned from the ventilator. They showed reductions in the shedding of virus, as shown by increasing cycle times required to detect virus by PCR. They had decreases in their multi-organ dysfunction score, improvements in oxygenation, and reduction in fever. There are some theoretical concerns that unless very carefully selected, these plasmas could also contain enhancing antibodies that might make the situation worse. And of course, there's also the concern for serum sickness and for transfusion reactions. But there are now many clinical trials underway around the world at multiple centers of a convalescent serum, and those results are awaited with great interest. Let me end by summarizing some of the challenges in conducting clinical trials of therapeutics in for treatment of respiratory viral pathogens. As we have come to learn from studies of influenza, it's clear that the benefit of antiviral drugs is maximal when the drug is started within the first few days after symptom onset. We also know that accelerated viral clearance from respiratory secretions is not necessarily a surrogate marker for clinical improvement with treatment of an antiviral drug. Immune-mediated lung injury is unlikely to be modified by antivirals, so when antivirals are started late, their benefit may be substantially less than when started early. And the availability of several candidates as approved drugs that can simply be prescribed, such as hydroxychloroquine, complicates the conduct of clinical trials where we're attempting to use these drugs in a controlled manner in order to obtain really valid data about their efficacy. Most likely, combinations of antiviral and anti-inflammatory drugs are going to be required in order to achieve maximal benefit and provide the best outcome for patients with COVID-19. Let me thank you for your attention, and I will turn this back over to our moderator for some questions.
Thanks, Dan. Another fantastic tour de force, and it's incredible how things are changing so rapidly in the therapeutics field, but we do need some more answers. Now, I just wanted to pin you down on this lopinavir issue because the New England Journal paper has just been formally published. Were there any new insights around lopinavir once you saw that paper?
Yeah, you know, things change so rapidly in this field that it turns out that the originally posted version had a critical typographical error that made it appear that earlier treatment provided statistically significant benefit. In fact, in the finally published paper that appeared in print and posted just a few days ago, it turns out that there is actually no difference, and the both that section and the discussion section of the paper were rewritten to acknowledge that fact. So there is no difference in outcome whether you start early or late, and there's really no statistical benefit at all of lopinavir-ritonavir use.
Well, I mean, it really is the key that we keep our eye on the ball for all of this and not just get fixed in our mind about preliminary results. We had that issue with HIV for many years about preliminary results coming out once a day, and Dinavir was it looked great, and then when the published results came out, it wasn't. So thanks for clarifying that. We've had lots of questions about therapeutics, and I hope we can tackle some of those in the round table. Thanks so much for that. As I say, a tour de force. So now we're going to move on to our next talk, and it's with great pleasure that I introduce Dr. Vikram Mukherjee. Now, Dr. Mukherjee works in New York, so you can imagine what that must be like and have been in the last few weeks and even, to date. But it also works as the director of the critical care there, the medical critical care. And so I can't think of anyone better to give us a review of critical care management of COVID-19 patients. Vikram, it's over to you.
What I'd like to cover over the next few minutes are in 4 broad categories. The presentation, who our patients were, what they presented with, some clinical characteristics, organ dysfunction, and we'll focus on 4 major organ dysfunctions in that subgroup, and then a brief idea of short-term outcomes. So starting with the clinical characteristics, our patients presented to the ICU in one of 2 ways. One, they had onset of symptoms. After 3 or 4 days, they presented to the emergency room with cough, fever, shortness of breath, and were slightly hypoxic to normoxemic in the EDs and were admitted to the floor. What we commonly saw, up to 1 out of the 4 patients who were admitted to the floor had worsening hypoxia, worsening pulmonary failure on the floors, and then were admitted to the ICU as a consequence of the need for a higher level of monitoring. Many of them went on to develop severe ARDS, requiring invasive mechanical ventilation and ventilatory strategies appropriate to severe ARDS. A few days after, the ARDS seemed to be stable or even improving, followed by them having a severe cytokine storm, and we'll talk about this later, following which renal failure ensued. Many of them went on to die. We'll come to the numbers in a bit, and many of them had ongoing ventilatory and renal replacement therapy needs. The other major route of entry to the ICU were patients presented to the ED with symptoms, and the symptoms were severe enough for them to mandate an ICU level of admission straight on. They were either very hypoxic or had respiratory distress or multi-organ failure at the time of their presentation to the ED. Morbidities. Strong male predominance, up to 72% of our patients were male. The common X-ray findings on admission, they were almost everybody, 80% of them had multifocal infiltrates. Barely anyone had clear X-rays. Some of them had lobar consolidations and interstitial abnormalities. And here you can see that this is the classic chest X-ray of a patient coming in with COVID pneumonia and COVID ARDS. Bilateral fluffy infiltrates. A lot of patients had multiple lines and tubes in them. As you can see here, this is an intratracheal tube or right internal jugular vein catheter. But these multifocal patchy infiltrates was almost universal in our patient population. The inflammatory surge that we saw, and I'll talk more about this in a bit, but a few days into their ICU admission, a significant proportion of our patients developed fevers, tachycardia, tachypnea, diaphoresis without, in fact, surge-like symptoms without any clear infectious etiology. And when we checked their inflammatory markers, they were all over the place. We had extremely high D-dimers, elevated ferritins, troponins as well. Elevated LDH was present in almost 100% of our patients, CRPs, IL-6s, and these were not mild perturbations of the lab values. These were CRPs in 300-400 range, IL-6s 5-6 times above the upper limit of normal. So gross inflammation leading to a vasoplegic shock. Almost all our patients in the ICU again had ARDS. Significant number, 70% were shock state. Very few of these were septic shock. Significant number were vasoplegic shock from the cytokine storm that was just mentioned. Renal replacement, a little bit higher than we expected. 1 out of 3 patients in the ICU needed either intermittent hemodialysis, continuous venous hemofiltration, or emergent peritoneal dialysis. 20% patients needed tracheostomy, and we'll come back to this again. And unfortunately, even within this is short-term mortality, not 28-day mortality, not 1-year mortality. We were looking at a mortality rate of around 55 to 60%. And remember, these were relatively young people coming off the streets with barely any pre-existing comorbidities. So this mortality rate is much higher than what is in a traditional ICU population. The organ dysfunction that we talk about fall broadly in 4 categories: ARDS, acute respiratory distress syndrome, the cytokine storm that we were alluding to a little bit ago, renal failure, and the hypercoagulable state. Again, a lot of this, the understanding behind the pathophysiology of why this occurs and what to do about it is in evolution. So things may change. Our understanding of this disease process itself will definitely change in the weeks to months to come. This is the descriptions following is based on best current understanding of how this virus behaves. Starting with acute respiratory distress syndrome, as you saw, almost all our patients in the ICU had ARDS. Close to 50% of them had severe ARDS. The others had mild or moderate. Conventional management, trial of high-flow nasal cannula. We started putting our patients on HFNC. Some of them, around 20-25% were able to stave off intubation with this. The large majority had high flow as a bridge to intubation. We intentionally kept away from non-invasive mechanical ventilation, the BiPAP devices, simply because there is pretty strong data to suggest that mortality worsens in patients who have ARDS and are treated with non-invasive ventilation. We tried our best to protect the lungs with lung protective strategy, 6 cc's per kg of ideal body weight, with permissive hypercapnia, with a CO2 55 to 60 targeted, a pH of 7.2 and above, and the permissive hypoxia with a gold SAT of 88 and above, and a gold PaO2 55 and above, 55 to 65. We were trying to follow the ARDSNet P2F ladder as much as we could. But that said, because our patients were sometimes in cytokine storm and were hypovolemic from the insensible losses, PEEP sometimes had a counterintuitive effect, as patients with higher PEEPs had worsening VQ and worsening hypoxia. Recruitment was attempted on a patient-to-patient basis, very individualized approach to peak titration there. Attention to fluid balance, again, very individualized. The traditional teaching of a dry lung as a happy lung was not always applicable, and we were seeing some renal failure, some worsening hemodynamics as we tried to diurese our patients aggressively. We tried antibiotics, more so as empiric in nature. Most of our cultures, at least early on, were negative, and after 48 hours of antibiotics with negative cultures, we were pulling off antibiotics after the first 48 hours. Our patients were very catabolic, very adrenergic, and needed high levels of sedation, not just fentanyl and propofol, but also ketamine and unfortunately Versed to stay compatible with the vent. To keep them synchronous with the vent, we had to use a fair amount of neuromuscular blockade in the form of Nimbex strips and so forth. We used inhaled NO for refractory hypoxia, and this is very topical here because often we saw acute cor pulmonale and were able to improve hemodynamics with the use of RB afterload reducer. We had manual proning. Significant, almost all our patients were prone responsive, and we were proning at 3 p.m. in the afternoon with the proning team, and supinating every morning at around 8 or 9 in the morning, the 16-hour prone window. And then as a salvage, when based on the Caesar and the earlier trials, based on if everything else was failing, then the lung protective strategy, the recruitment, the neuromuscular blockade, they needed NO and proning, and the patients were still refractory and hypoxic. We had ECMO, VV ECMO as an option. We cannulated 5 people so far who have been on VV ECMO. 2 of them have been decannulated. 1 unfortunately has passed away. 2 of them are still on the circuit. Other issues, central lines and A lines were placed during the time of intubations. We prefer the left IJ central venous line for our venous access, keeping the right IJ for renal failure, which often are needed dialysis. We left the subclavians alone because of the risk of pneumothorax in a patient with such severe ARDS would be a pericard situation. We left the femorals alone just because of the risk of CLAPSIs in that region. As mentioned, many of them had substantial sedation requirements, and many of them needed neuromuscular blockade to achieve ventilator dysynchrony. We quickly ramped up a tracheostomy team, knowing that these patients had severe ARDS, needed deep sedation and blockade, and would require long-term weaning to come off the ventilator. We quickly formulated a surgical tracheostomy team, which was protocolized and did above 30-35 bedside per trach so far. Our initial experiences based on existing data at that time was to try a Plaquenil and Azithro, but of course we watched the QT for prolongation very, very closely during that time. The second organ dysfunction, if you may, I want to allude to is the cytokine release syndrome. Very common, very surprising from a viral sepsis perspective, but almost universally in all our patients we saw a few days into the ICU course, marked fevers, tachycardia, tachypnea, diaphoresis, no obvious infectious sources despite culturing blood, sputum, urine, stool, what have you. And this was, the cytokine storm was manifested by extremely high CRPs, ferritins, LDHs, IL-6s, D-dimers as well, though now we realize that some of the D-dimers were a marker of hypercoagulable state and thrombosis. Many of our patients then progressed to renal failure, and we really still don't know how to mitigate the cytokine storm. We tried steroids, of course, knowing that this was a double-edged sword. With the Nimbex with the paralytics on board, the risk of neuromuscular weakness with steroids is extremely high. The risk of bacterial and fungal superinfection was high. We tried 5 days of steroids. Data will show whether it actually worked or not. We tried anti-IL-6s, tocilizumab, on select patients. But again, these I would like to emphasize are not data-driven therapies. Hopefully over the months to come, we will actually have some data to show us what works and what doesn't work. Renal replacement therapy, a surprisingly high incidence of acute kidney injury in our patients, in almost all patients in the US, much higher than the literature in China suggested. So we were trying CVVH in our patients who could tolerate it. And as we ran out of CVVH machines, we quickly moved to emergent PD, a peritoneal dialysis, which worked quite well to be able to provide RRT to our sick patients. And the last organ system dysfunction I'd like to just go over is the hypercoagulable state that SARS-CoV-2 brings with it. Up to 25-30% of our patients had a reason to initiate therapeutic anticoagulation. And as in real time, we were seeing a lot of clots. People were becoming hypotensive with blown out RVs and clots in transit as we echoed and focused them at the bedside. And this was in the setting of therapeutic anticoagulation with heparin or Lovenox. Now, again, unclear etiology, autopsy studies suggest that there is a virus-induced endothelial damage, inflammatory cascade follows. We were using the D-dimer as a surrogate of clot formation, given that transporting a patient with COVID to the CT scanner and back, or getting doctor to the CT scanner and back was difficult. We did a lot of point of care doctor ultrasounds to look for objective clot in the FEMS, in the lower extremities, but only 2 or 3 of them were positive. So we were able to, we were initiating therapy with therapeutic anticoagulation based on D-dimers to a large extent. Other considerations again, I want to emphasize, there is no evidence-based treatment yet. Critical care support is the mainstay of therapy. There is some newish data on remdesivir, but again, that is not in an ICU population, and it hasn't shown a mortality benefit. It does show that it cuts your hospitalization rate, but I would like to see stronger data before making that a strong therapeutic tool. We know that hydroxychloroquine doesn't work based on an observational study coming out of New York. We don't know if the tocilizumab or the steroids or the or any of the plasma products or any of them have any evidence behind them to work. Alter standard of care, definitely huge role of the point of care ultrasound in being able to go through the differentials of hemodynamic compromise, of respiratory failure, of blood clots, what have you. And we were lucky that we had enough ultrasounds and ultrasound experts in our team to be able to do this on a regular basis. The last thing, as you see this in your ICUs, you will notice that things move very slowly, and this has repercussions on management choices. For example, just the levels of sedation. In routine life, we wake up our patients every morning for a spontaneous awakening trial and a spontaneous breathing trial as a bridge to getting them off the bed. This is tricky in a patient with COVID precautions, just because it takes easy 5 to 7 minutes to dawn and go into the room. And as you wake sedation, patient off sedation, self-extubation can be risky, and it takes a few minutes to be able to stop them from doing that. So plan and take care of things in a more paced. Lastly, I cannot emphasize enough that you will need a multidisciplinary approach. You will need a lot of your colleagues to help you through a crisis with a novel virus such as this. So for example, in the patients who would need long-term weaning off the ventilator, you should be building you might have built a tracheostomy team, a proning team to help position and reposition your patients every day, a palliative care team to help connect the families with the loved ones in the ICU, a procedure team to help with your central lines, your A lines, your intubations and so forth, a dedicated renal replacement therapy team given the high incidence of need for renal replacement and peritoneal dialysis, and of course a site manager team that would assist with making sure their supplies and resources are where they should be.
Thank you so much, Vikram, for that. And you know, I always learn a huge amount, and great admiration for you guys right at the sharp end of things. I just wanted to ask you about the use of CPAP. We've heard that NIV, a BiPAP, is associated with increased mortality. Where's the role of using CPAP? We used it a lot in pneumocystis care for the HIV patients, but what about these COVID-19 patients?
Thanks, Anton, and that's a great question. Till data further supports the safety of using CPAP in this setting, I would recommend using it with a lot of caution. Many of these patients become encephalopathic and have multi-organ failure, and a CPAP might just delay a life-saving intubation. So in my mind, a CPAP is just as dangerous as a BiPAP and should be used in with extreme vigilance.
And it seems, thanks very much. I think it seems to me that the coagulable state has led to a lot of serious morbidity and mortality and difficulties for you. When patients come into hospital with COVID, we obviously prophylactically anticoagulate them. Do you think there's we should fully anticoagulate all patients that come in with COVID, or and what should we do? What do you think about that as an idea?
Yeah. Again, a very good question. I mean, anticoagulation at a therapeutic level is still a double-edged sword because of the risks of bleeding, and resuscitative efforts might not be as aggressively delivered as in routine care. What we used here was D-dimers as an index of occult clot. So we were using a rapid elevation in D-dimers or D-dimer level higher than 3,000 to guide us towards anticoagulation. We are one of the study sites for a prospective study looking at how and when to anticoagulate patients with COVID, and hopefully some data will come out pretty soon.
All right, thank you very much. Again, an evolving field. I think we'll learn a lot from COVID about managing patients in the ICU for other conditions. Now, I'd like to move to the round table. So if Dan and Yonathan, if you could join us now. And Yonathan, there was quite a lot of people who asked, is there cross-immunity between the coronaviruses? What can we know about that?
It's a great question, and the short answer is we don't really know about the extent of cross-protection from the existing coronaviruses to the novel SARS-CoV-2. We do know that there is asymmetric protection in that people who have been exposed to the common cold beta coronaviruses do not seem to have protection against SARS-CoV-1, but people who had SARS-CoV-1, their antibodies seem to protect against the circulating beta coronaviruses. So there's much more there that I think remains to be understood about the extent and direction of cross-protection.
Okay, so it's a really evolving field, and we really need to know about also about whether antibodies could be harmful from those other coronaviruses in terms of enhancing disease.
Right. There's been some theoretical concern about the possibility of antibody-dependent enhancement, although we haven't really seen that for other coronaviruses. Although the concern remains a theoretical possibility, it seems like there hasn't been substantial evidence to support that as a major concern.
Okay, thanks. Dan, there's been quite a lot of questions about inhaled therapy, and I mean, beta interferon is being used, but what about other inhaled therapies? I mean, you know, most of the disease and destruction is happening in the lung, and you avoid systemic drugs by doing that. So is there any news on it?
Well, you know, most of the trials are using some form of systemic therapy, and as Vikram nicely pointed out, this is a systemic disease, especially when you get to the cytokine release syndrome. One of the challenges of delivering inhaled therapy is getting the drug particles to be fine enough that they actually make it all the way out to the distal airways and into the alveoli. And so while occasionally drug delivery and drug penetration into the air, the smallest airways can be a challenge. We know, for example, aminoglycosides don't get into the lung very well. There are many other antibiotics that do penetrate quite well into the lung, and usually we prefer, in most settings, intravenously administered therapy. But Vikram is a specialist in critical care and probably better able to speak to this modality than myself.
Yeah, we had a problem with pentamidine, if you remember, in treating.
Yes, I do.
Yeah. So Vikram, inhaled therapy, are you using anything? I mean, there've been some talks about famotidine as being useful. So
yeah, I saw some promising data on that, and there's some talk about pulmonary embolism being a cause of respiratory failure, and inhaled forms of anticoagulation. What I worry about is that the alveoli in these patients are so filled with pus and protein and cellular debris. How much of that will actually be absorbed to cause any efficacy? Inhaled nitric oxide definitely has a role to play in improving P2F ratios, but I don't know about the others yet.
Okay. Yeah, so much experimentation going on. Now, I just wanted to change tack a little bit about masks, right? So there have been so many questions about masks. And now we've been told in the UK, if you're in an enclosed place like the metro, the tube, the underground, we should be wearing a mask. And if you're going to wear a mask, what sort of mask are you going to wear? Now, Vikram, on the ICU, I think you would give me a very specific answer.
Yes, so in the ICU, in the hospital, we are wearing surgical masks all the time. And in the ICU, because the risk of aerosol generation from a critically ill patient is so high, anytime we are seeing a patient within 6 feet, we are wearing N95s and face shield with gowns and gloves.
But Yonathan, if we're going down your sort of number 3 of quarantine, social distancing, where does the mask fit into that? And what sort of mask should people wear?
So I can't say that I'm an expert on all the different varieties of masks that are out there or that are available, but I think generally speaking, the argument is that when there are opportunities for transmission, masks serve 2 purposes. One, to prevent transmission from individuals who may be infected, either asymptomatically or perhaps mildly symptomatically. So by blocking large droplet spread, and then 2, for individuals to help reduce the likelihood of acquisition. So I think, in contexts where that kind of contact is likely, masks will serve a greater purpose and should be considered.
Okay. Dan, any thoughts on masks before I'm going to ask you about prevention? But first of all, what about masks?
Yeah, well, so I think that clearly in the healthcare setting, when faced with a patient with direct interactions in a high-risk procedure, obviously N95 masks and face shields are the way to go. For the general public, I think as Yonathan was saying, the reason to wear masks are, number one, if you yourself are carrying the virus and don't know it and are shedding virus, that you can reduce the risk of spreading it to other people. There may be some modest protection that wearing a mask, a routine surgical mask or self-made mask provides from acquiring infection. That's going to be more effective at stopping droplets than at stopping transmission by fine aerosols. But I think it also serves a purpose of reminding everybody how important social distancing is, and to be mindful of all the other things you can do to protect yourself and to protect your friends and family.
Yeah, I know. I mean, I wear one when I go out in a crowded place, and people look at you and then move away. I mean, it is a good reminder. I do agree with that. Now, Dan, another form of prevention is therapy, and we've seen this in many diseases, in HIV, where we have PrEP, and people have been talking about hydroxychloroquine and other drugs. Where are we with that with COVID-19?
There are an astonishing number of studies now underway to look at different approaches to prevention. And these take, as they do with HIV, 2 forms. One would be post-exposure prophylaxis, where there's been a known discrete high-risk exposure. And then the other is more of sort of pre-exposure prophylaxis. Can people who are likely to come into contact with individuals who are infectious from COVID-19 be prophylaxed on a more extended basis? And there are several studies looking at hydroxychloroquine. I think some of those studies may need to be reassessed as more and more data come out about the apparent lack of utility of hydroxychloroquine as a therapeutic, albeit not yet a formally executed randomized clinical trial. But just today, JAMA published another paper on the experience in New York State with hydroxychloroquine, showing that it really didn't have any obvious benefit when compared to people who didn't receive the drug, not randomized. And then there are some other small molecule inhibitors like favipiravir that if shown to be effective in a therapeutic setting might be candidates for prevention. Remdesivir is intravenous, and so that would be a little harder to use. But serum could have a potential protective role, or even better than serum would be concentrated forms of hyperimmune globulin, or broadly neutralizing antibody. And there are several companies that specialize in this area that are actively working at cloning B cells from infected individuals and turning them into little factories, the cells, not the people, into little factories to make high titer BNAbs, and those could be used for prevention in theory, just as they are being explored in HIV and in other viral diseases.
Mm. And what about the good old tenofovir, which has been mooted as something to give to healthcare workers?
Yeah, well, there isn't strong evidence from in vitro studies or animal model studies for tenofovir having a significant antiviral effect against coronaviruses. There's been some speculation about whether or not people receiving PrEP for HIV are at lower risk for presenting with severe SARS-CoV-2 infection. And I know there's at least one ongoing trial by Jose Arribas in Spain of tenofovir, and we'll have to see what the data show.
Okay, thanks very much. I'd like to just turn to about the tolerance for a second wave and a second lockdown. So I'd like your opinion from all of you. Yonathan, what do you think the societal view will be if we all have to, after coming out, even for a short while, or relaxing what's happening now, told to all go back inside because the health service are being overwhelmed again?
Right. I think this gets at an extremely important point. Yes, I totally agree that the political and social will to sustain a second round of lockdown, where we think of mass quarantine really as this blunt instrument, is unlikely to be there. And instead, what that really underscores is the importance of careful monitoring, extensive testing, and thoughtful approaches so that when we do see the inevitable resurgence in virus, we can apply more measured interventions. Again, this has long been one of the ideas of of social distancing to begin with, that it will give us time to develop these approaches. It seems pretty clear from the plans we're seeing from multiple quarters that those don't yet really exist. And rushing into opening, I think, will again put us right back to where we started, and again risks whatever gains in time and the benefits we've accrued from distancing so far. So I totally agree. A second round of distancing to this extent is unlikely to be tolerated, and it emphasizes just how much we need to be careful and thoughtful about the strategies we take in emerging.
Vikram, if your staff, all right, they all get relaxed because it all goes down and then suddenly it all comes back again, just give me an idea of what you think the mood might be like. What's it going to be like for them?
Anton, I mean, morale is going to take a huge hit. We saw even last month when we were at the height of our pandemic that mental health and staff morale was a really important issue to address, not only because of the death and demise that was happening multiple times through the day in the ICUs, but also when healthcare workers, our nurses physicians were falling sick and dying in our ICUs. That really burnt out a lot of our staff. And looking at when this inevitable second wave does happen, I think we need to pay a lot of attention to healthcare worker morale, making sure that they are able to take care of themselves as they take care of their patients and so forth.
Yeah, well, thank you very much for that sobering thought. I'd like to thank the panel for a great discussion. It's really interesting. We could be here all night, I know that. But really, Yonathan, Dan, Vikram, thank you so much for that roundtable discussion. And we hope to hear more updates as this COVID-19 scene unfolds before our very eyes. And I keep saying we are living through history. Thank you so much.
Thank you.
Bye, everybody.
Okay, so I'd now like to thank you all for listening to this webinar, and I hope you really enjoyed the presentations as much as I did and the faculty did, and that you've learned some new things tonight. I'd also like to thank our supporters who are on the slide here. Thank you so much for supporting this program. Without you, we wouldn't be able to present this, so a sort of virtual round of applause to them. And then I'd like to just let you see that we have got the materials online. If you visit us here, there'll be materials and more information, the slides, and you can watch this again. So I'd like to really thank you extremely very much for being a fantastic audience. We've had lots of questions, and again, I'm sorry if you didn't manage to have your question answered, but please stay tuned, because we are going to have another edition, and that is going to be on Tuesday, the 2nd of June. And you can see the timings here, depending on where you are on the planet. And we look forward to meeting you all again virtually at that time. And who knows how long we're all going to be inside, but let me wish you a wonderful rest of the day wherever you are, and keep safe and keep well. Thank you.